Welcome all of you to this high yield revision session for NEET PG. So I'm Dr. Jazeer Abdul Qadir, your dermatology faculty at PW Meded. So the topic that we are going to discuss today is a very important one, that is atopic dermatitis. So whoever is online, kindly let me know if my audio as well as video is all clear for you. So as soon as you confirm, I shall continue further. Thank you so much. So you must be knowing that if you have gone through all these previous years MCQs, like the PYQs, one question from atopic dermatitis from dermatology is for sure, isn't it? Because this is going to be a very high yield topic, because all of those NEET PG exams, every time one topic is asked from the eczema, and from the eczema part, more than contact dermatitis or anything else, they usually test you with atopic dermatitis. So we would be having a very detailed conversation today regarding this atopic dermatitis. We'll try to understand what is this disease pattern, how does the patient present to you, what are the things that you have to look for when it comes to atopic dermatitis. We'll also talk about some of the important treatment aspects as well. Fine. So I hope that everything is fine, and with your permission, I would like to continue further. So welcome to this session, and let us start with a brief introduction about this topic, that is atopic dermatitis. Now, what is atopic dermatitis? The word atopy itself, it means allergy. So the word atopy itself means that this is going to be allergy. So dermatitis, we all know that there is going to be some skin symptoms as well. Now, what is this atopic dermatitis? It is a chronic relapsing inflammatory condition of the skin. Inflammatory condition of the skin. Now, this is a chronic condition, which means the patient is going to have the symptoms for a long period of time. Relapsing, it means that the patient can go into flares as well as remissions, and it keeps on coming and going. So that is why we call it as a relapsing condition, and there is some inflammatory process which is happening as well. And now in all these cases, the patient would be having a history of atopy. So whenever a patient is having a history of atopic diathesis, so what do I mean by a history of atopic diathesis? So by atopic diathesis, I mean that the patient would be having either a personal history, one can be a personal history, or it can be a family history, or it can be a family history. So a personal or a family history of atopy, like it can be bronchial asthma, it can be allergic rhinitis, so hay fever, allergic rhinitis, all these things comes under a personal history where the patient himself will be having this, or there would be a family history as well. So this is one of the important things that comes under atopic diathesis. So along with this atopic diathesis of a personal or a family history, there may also be a increased serum IgE levels as well. So these two comprises of the atopic diathesis that is associated with atopic dermatitis. Now let us talk about who are those patients who usually would be getting this atopic dermatitis. Now remember, these are the patients who usually would have that itch, scratch, itch cycle. So these are the patients who usually have the itch, scratch, itch cycle. What do I mean by this itch, scratch, itch cycle? The patient would be having some sensation of a itchiness. So whenever a patient gets the sensation of a itch, they would be obviously scratching over the skin. So once the patient scratches over the skin, again what happens? This is a cycle that continues, and after which a rash will develop as well. So first there is a sensation of itch, the patient would be scratching over the skin, and then some rashes would be developing, and this continues just like a cycle. So hence we call it as the itch, scratch, itch cycle. That is very typical of atopic dermatitis. Now always remember, when I talk about atopic dermatitis, what is the kind of patient that you have to imagine in mind? So the kind of patient that you have to imagine in mind is someone who has allergy for almost everything. Like somebody who comes to an environment which is dusty, they start repeated sneezing, they start getting wheeze. So someone who is who takes something not normal in their diet. Let us say that somebody who takes some milk products, someone who consumes peanuts, and suddenly they feel like there is an increased itchiness over the skin. So anything kind of an environmental factor, sometimes food, sometimes dust, all these things can contribute to an allergy, and these patients would always and always present to you with a dry skin. So there is always going to be this one, that is a dry skin. So this is the kind of patient whom you can imagine for atopic dermatitis. Now let us see how do you classify this disease. Now the classification of atopic dermatitis is mostly based on the age of the patient. Now if you have a patient who presents to you from birth up to 2 years of age. So from birth up to 2 years of age, the presentation is going to be slightly different from what is the presentation after 2 years of age. So when a patient presents to you from birth, the patient would be complaining of a dry face plus rash. So the patient would be having a dry face plus rash. Along with that, you may also find the lesions over the extensor surfaces. Extensor surfaces. So whenever we talk about atopic dermatitis, the kind of skin that comes to your mind should be something like this, which is going to be a dry skin. So along with this dry skin, where do you find the rash when it comes to a baby? Let us say a 6-month-old infant or a 1-year-old infant or up to 2 years of age. So up to 2 years of age, this usually is seen over the face of the patient. The patient would be having a very dry skin. So along with this dry skin, obviously there would be itchiness of the skin. And then you can also examine the extensor surface. So the area important that you have to remember is the extensor surface, because just try to imagine that these are crawling infants. So once they would be crawling, which is the area that is getting in contact with the environment, that is going to be the extensor surface, and they would be having a rash over the extensor surface. So please make a note of it. Very important point, that facial rash along with extensor surfaces rash is what can be seen when it comes to atopic dermatitis in an infant. Now, coming to the other age group, easy to remember in this way, even though we can classify atopic dermatitis as childhood and adulthood AD, but still let us try to write down the symptoms of child as well as an adulthood together, because after 2 years of age, like after 2 years of age up to adulthood, what happens is that you will not find any rash over the face. Instead, where are you going to find the rash? The rash is going to be over the flexural surfaces. Over the flexural surfaces is what you can find the rashes. Now over the flexural surfaces, the kind of rash that you can see is going to be again a dry skin. The patient would be complaining of an itching, and the most important thing is the most common site for your MCQs, the most common site is going to be the antecubital fossa. So it is going to be the antecubital fossa where you can find the rashes or any child who is more than 2 years of age and also in adulthood. So any MCQ which says that the age of the child is 2 years, 5 years, 10 years, or in the puberty time, or in the adulthood, let us say 24 years of age. Every time where is a place that you have to look for the rash, you have to look for the rash over the antecubital fossa, which is the most common site, or the flexural surfaces. So all the flexures is where you can see. So these are the images for you. The first image is a dry skin over the face. It's an infantile AD. Whereas when it comes to a child as well as an adult, you can see that the rash is present over the flexural surfaces. Now, when there is a rash which is present in the skin for a longer period of time, just like what you can see in an adulthood AD, then what you have to also see is you can also find a lichenified rash. So what do you mean by a lichenification or a lichenified rash? is that you can see that the kind of the rash that you can see is, you can remember it as HIT. Now what is H? H means there is a hyperpigmentation. There is hyperpigmentation. So along with hyperpigmentation, you can also see there is a increased skin markings, And finally, once you palpate over the skin, you can feel that the skin has become more thickened. So there is a thickening of the skin. So in adulthood AD, what happens is, since the rash is present over the skin for a longer period of time, it is going to be a severely itchy rash. So what will the patient do? They would be constantly rubbing over the skin. So once they repeatedly rub over the skin, you can also see some signs of lichenification. So the signs of lichenification, please remember it as HIT. So there would be some area of hyperpigmentation. There would be increased skin markings. The lines over the skin will be more visible, and there will be a thickening of the skin, which we can appreciate once we palpate over the rash. So these are the various findings that you see on a chronic type of an eczema or in the chronic type of an adulthood AD. Now coming to the etiological factors, what is responsible for the occurrence of this atopic dermatitis? Well, the causes vary. The causes, they actually vary. So there is no specific cause which we can say that that is responsible for the development of atopic dermatitis, because multiple things has been proposed. First of the thing is going to be immunological. So in immunological, it can be because of an altered immunological response that a patient may develop this kind of an atopic dermatitis. The second one, what is being proposed, is due to a barrier dysfunction. So the second one is going to be due to a barrier dysfunction. So when I talk about a barrier dysfunction, what usually happens in atopic dermatitis is there may be this ceramides as well as filaggrin. So their levels may decrease, which can lead to a dry skin, and ultimately the patient can have some pruritus and may complain of symptoms of atopic dermatitis. And along with that, some environmental factors also plays a role when it comes to the etiology behind atopic dermatitis. So immunological mechanisms play a role, barrier dysfunction plays a role, as well as environmental factors also plays a role in the etiology of atopic dermatitis. So I hope that these things are clear for you. Now coming to the next one. Now, what are the controlling factors for exacerbation? Now, like every time you get a patient of atopic dermatitis, what is a complaint? They are extremely disappointed with their skin. Reason is, they would be complaining that, see doctor, whatever I do, like if there is a change of an environment, like I go for a tour, some places where there is a change in the temperature or any change in environment, I start getting uneasiness over my skin. Like for example, if I take any of the food items, if there is a change in my diet, like again, it is going to be a problematic condition, because I start getting pruritus as well as some rashes over my skin, and there is extremely itchiness as well. So sorry, so all these are the things that is going to happen with the patient of atopic dermatitis. Now what are those controlling factors for exacerbation? The controlling factors for exacerbation, the first one can be food allergy. So we need to ask the patient, like, what do you think is going to cause some exacerbation? Like what are the common food items that you think is causing some exacerbation? Now in this thing, usually what comes is milk and milk products. Peanuts is reported multiple times. So some seafood can also cause some kind of an allergy. So all these things can cause this kind of allergy. Especially sometimes the patient can complain of an allergy whenever he takes egg products as well. So someone takes some omelette, someone takes a bullseye, then what happens? The patient is getting this kind of a symptom. So milk and milk products, peanuts, eggs, seafood, all these are going to be the common causes which causes food allergy in these kind of patients. Now, second one is that you must have noticed that every time we always give advice about the clothing of the patient. Because if the patient is going to wear some kind of a woolen cloth or nylon clothes, all these are going to cause some kind of an allergy, because whenever the patient wears this woolen or nylon clothing, or when you say occlusive dressings, so all these things are going to cause some kind of a skin irritation once again. So what do we recommend? Like, we would always recommend, so the recommendation from our side should be that we would try to recommend that the patient may be wearing some loose clothings, that is loose clothings. And what kind of material is recommended? We always would like to recommend cotton materials. So cotton materials is the best, that is going to be the best as far as the patient of atopic dermatitis is concerned. So there are some of the environmental factors as well, and along with that, one of the factors would be sweating. So whenever the patient sweats a lot, the patient may be having more of a symptoms as well. So whenever the patient has some physical exertion or some sports activities or anything, when the patient is sweating, we always would like to advise the patient that please take a quick shower, because a quick shower, when you wash off the entire sweat, the symptoms may not occur as expected. And finally, the last factor that we can actually control is the environmental factors. So in the environment factors, we will ask the patient to avoid a sudden change in the environment, sometimes going and playing in the park for a long period of time, because more of the children may also be affected, right? So these are the various factors which can be controlled. So just see what are the food items that can be avoided. Just see what kind of clothing will make this patient get better, and then see that the patient doesn't sweat a lot, and just try to control on the environmental factors as well. So all these are the major factors. Now coming to the diagnosis part, how do we make a diagnosis? The diagnosis can be made is easy, because whenever the patient is having atopic dermatitis, dry skin to pakka hai na? So whenever the patient is having a dry skin with itchiness and all, we have to look for the family history or a personal history of atopy as well. Now, diagnosis is basically mostly based on a criteria, and the criteria is called Hanifin and Rajka criteria. Hanifin and Rajka criteria. So this is the criteria that is our reference for the diagnosis of atopic dermatitis. So please remember this name. In fact, this criteria was made in the 1980s, and after which the UK health system as well as the American Academy of Dermatology, they have made some modifications according to their regions so that they fit into the criteria well. So even in India, Hanifin and Rajka criteria is being followed. And in this Hanifin and Rajka criteria, please remember one very important point, that this disease, that is atopic dermatitis, is something where it is going to be 100% clinical diagnosis. So when I say that this is a disease which is having 100% clinical diagnosis, what I mean to say is none of the investigation is necessary to make out a diagnosis. So remember that no investigation is necessary to make a diagnosis. So if a dermatologist tells you that you are a patient of atopic dermatitis, just agree. The reason is, there is a specific reason why they would be telling you that you are a patient of atopic dermatitis, because we have a criteria as well. So now let us try to understand what is this Hanifin and Rajka criteria. See, in Hanifin and Rajka criteria, there are major criteria as well as minor criteria. Remember, you have to score at least 3 out of 4 in the major criteria, as well as 3 out of 23 in the minor criteria. So there are 4 major criteria and there are 23 minor criteria, out of which majors we should have at least 3, and as well as in minors we should have at least 3. So 3 out of 4 and 3 out of 23 is required to make out a diagnosis. Now coming to the important part, what are the features of the major criteria? Now, pruritus is present, typical morphology and distribution of the rash is there, chronic relapsing dermatitis is there, a personal or a family history of atopy would be there. So these are the 4 major criteria. Now, how do you remember this 4 of the major criteria? The easiest way to remember is you can ask the patient 3 questions. So you can ask the patient 3 questions and you can do one clinical examination. One clinical examination. That is how you can remember the major criteria. Now, what are the 3 questions that you would ask any patient who comes to your OPD? And then you are going to ask the 3 questions. First question is, do you have itchiness over the skin? That is called pruritus. The patient is obviously going to answer, yes, I'm having severe itching over my skin. It comes and goes. The second kind of question that you'll be asking is, do you think that this is a kind of a skin problem that you're facing since long? Or do you feel that sometimes there is a flare, sometimes there is a remission? There is a flare, there is a remission. Obviously, for this also the patient would say yes, because the patient would say that since my birth or since childhood, I'm having this problem. Any change in environment, I'm getting the skin disease. Sometimes it goes into a flare, sometimes it goes into a remission. So that is the second question. Third one is, you're going to ask the patient, do you have bronchial asthma, bronchial asthma, allergic rhinitis, hay fever, something as such? Even if the patient says that no, I don't have this problem of a wheeze, but if you ask a family history, the patient would be saying that yes, my parents are having this problem or my siblings are having this problem. So there would be some family history of atopy that is also going to be there. So that is going to be personal or a family history of atopy. So remember 3 questions: whether there is any itching, whether there is a chronic course of the disease, whether there is a personal or a family history of atopy. Now, what is that one clinical examination that we would do? The one clinical examination that we are going to do in this case is going to be, you are going to check for the rash. Now, where do you look for the rash if the child who has come to you is up to 2 years of age? जैसे 6 months का infant हो या फिर 1 year of an infant, then where do you look for the rash? Obviously, yes, you are going to look for the rash over the face as well as over the extensor surface, because that is what we have learned in the clinical features. The second one is, if the age of the patient is going to be more than 2 years, then you are going to look for the involvement of the flexural aspects. You are going to examine the antecubital fossa. You are going to examine each of the body folds or the flexures of the patient, where you can look for a lichenified rash or a chronic type of a rash. So that is about the typical morphology and distribution. So this is going to be a clinical examination. So this is going to be the clinical examination. That is about the major criteria. So how many major criteria is required? 3 out of 4. Now we have a long list of minor criterias. Now let us see what are the minor criterias one by one. So the first one, it means cirrhosis. What do you mean by cirrhosis? There would be a dry skin. So cirrhosis means this is going to be a dry skin. Obviously, yes, the patient is going to have a dry skin. Ichthyosis or palmar hyperlinearity or keratosis pilaris. So this keratosis pilaris is also called as the antenna sign. So this is also called as an antenna sign, because what happens in patients of atopic dermatitis who has keratosis pilaris is that there would be a small follicular papule. There would be a small follicular papule, and this hair follicle would be coiling around this hair follicle and look something like this. So it looks like an antenna, hence we call it as an antenna sign. Now, what is the meaning of ichthyosis? Now, this one called ichthyosis, what is the meaning? Ichthyosis means fish-like scaling of the skin. So all these can be seen. Next one is immediate skin test reactivity. Like if you have a prick test and all, if there is a type 1 type of hypersensitivity, then yes, that also adds to the minor criteria. In some of the patient, not necessarily all. In some of the patients, you may get a serum IgE levels as elevated as also. But remember, even though serum IgE levels is elevated, in the clinical course of the disease, we never recommend that every time the patient comes to you, you have to check for the serum IgE levels. Okay, at the time of diagnosis, you can definitely do. So that it just adds to one of the points to the minor criteria, but that is not a necessary investigation for the diagnosis of an atopic dermatitis patient. Now, early age of onset, that is also one of the minor criteria. Tendency towards cutaneous infections. Now, this is severely itchy skin disease. Now, what will the patient do? They'll be repeatedly itching over the skin. Now, once there is a repeated itching over the skin, there may be some cracks over the skin. Over these cracks over the skin, the patient can develop secondary bacterial or viral infections. The most common infection associated is going to be Staphylococcus aureus, which is a bacterial infection. The most common viral infection that is associated is going to be herpes simplex virus infection. Now the next one is tendency towards non-specific hand or foot dermatitis, because basically they are going to have a dry skin, so they may be having a more tendency toward hand dermatitis and foot dermatitis. Nipple eczema is also been reported. Cheilitis around the lips is also reported. Recurrent conjunctivitis is also reported. Denny-Morgan fold. I have an image of a Denny-Morgan fold today. So I'll be showing this Denny-Morgan fold image in a while. Keratoconus, when you get this cone-shaped lesion over the eyes, this is called as keratoconus. Anterior subscapular cataract is reported. Periorbital darkening or orbital darkening can also be seen. So this is also called as the allergic shine. So this is called as the allergic shine. So the orbital darkening can be seen. Facial pallor or facial erythema. Pityriasis alba, which is also when a patient may complain to you with hypopigmented patches over the face. So the patient usually presents with hypopigmented patches over the face, can be seen in pityriasis alba. So that is also seen as a minor criteria. Anterior neck folding. So all these things comes under the minor criteria. See, out of all these minor criteria, the important ones like the white dermographism, the orbital darkening, pityriasis alba, Denny-Morgan fold, cheilitis, all these things I have added some images so that your understanding would be better. Fine. So remember, how many things are required in the major criteria? 3 out of 4. How many is required in the minor criteria? 3 out of 23. So that is required to make out a diagnosis of atopic dermatitis. Now let us see some of the images also. Now this is an image of the cheilitis which you can see. So this is called as lip lick cheilitis. So this is called as lip lick cheilitis. So why is the name called lip lick cheilitis? Is because of a very dryness over the lips. What is the first thing that we will do? Is that probably you may be thinking about a lip balm right now. Now, if there is no lip balm, the first response is that we would be wetting the lips with our own tongue, like this, isn't it? So once we wet the lips repeatedly with our tongue, what happens is that you can find a hyperpigmented rash, some darkening that happens around the lips area. So this looks like a headlight of a bike. So what should be the name of the sign? Yes, this is called as the headlight sign. So this is called as the headlight sign that you can see in atopic dermatitis. So this is one of the minor criteria. So remember, headlight sign is seen as a part of lip lick cheilitis in atopic dermatitis. Now let's see the second image. Now in all these patients, they are going to repeatedly rub over the skin. So if somebody rubs around the eyebrows like this repeatedly, so because of this repeated rubbing around the eyebrows, the patient may lose out on the lateral part of the eyebrows. So when there is a loss of lateral eyebrows, we call it as Hertog sign. Which is also seen in atopic dermatitis. So this is Hertog sign. So the loss of lateral eyebrows, you must have learned in many other diseases, like it is usually called as a lateral madarosis. So lateral medrosis you must have learned in leprosy, in hypothyroidism, etc. But remember, this is Hertog sign when it comes to atopic dermatitis, where a patient can be complaining of a loss of lateral eyebrows. And what is the reason? Because of repeated rubbing over the eyebrows, over the eyebrows. So that is called Hertog sign. That is called Hertog sign. Now moving to the next one. If you find this kind of a skin, sometimes you can compare it as ichthyosiform skin, isn't it? Like you get a fish-like scaling over the skin. You can also compare it as a crazy pavement pattern because it looks like a very dry skin with a crazy pavement pattern. Now generally we can call this as xerosis. Now, what is xerosis? Xerosis means this is going to be a dry skin, which is going to give you a certain kind of a pattern over the skin. So you must have experienced these kind of a xerosis even in normal individuals during the winter seasons, isn't it? So whenever the climate is cold, our skin automatically becomes dry. And this kind of a finding, if you find, is called as xerosis. This is called as xerosis. Now moving to the next one. Now, what is this? Now, these are the patients who always has allergic rhinitis. So when they get this allergic rhinitis, they frequently will be sneezing. Like once they get up from the bed, they may be sneezing multiple times. So once there is some dust allergy, they will be sneezing multiple times. So because of this repeated sneezing, this patient would be frequently doing this action over the nose. So because they do this repeated action over the nose, they may develop a hyperpigmentation, a line, a transverse crease that may form over the nose. And this is called allergic salute. Allergic salute. So remember, this one is not this salute. This is allergic salute because of this action, like what you can see over this image. Now, this is due to repeated action of this patient, and because of which there is a hyperpigmentation that develops. There is a hyperpigmentation that develops over the nose. Over the nose. So this is usually going to be a transverse line over the nose, and this is called as the allergic salute. Fine. So now moving to the next one. Now what is this? A very important image, I would say, that for the NEET PG exam. So they can give you this as a spot diagnosis as well. Now what is this phenomenon that is being shown in the image right now? So just imagine I have taken my pen and I'm going to do a stroking over the skin of the patient. So once you do a stroking over the skin, like I have done a stroking like this over the skin. So after stroking over the skin, if I wait for a few minutes and then I examine the skin, what am I going to see? What I can see here is that part of the skin has gone into vasoconstriction. So once that part of the skin has gone into vasoconstriction, there is a whitish discoloration. So can you see this whitish discoloration? So there is a whitish discoloration that happens due to vasoconstriction. So this is called as white dermographism. This is called as white dermographism. So what is white dermographism? This means that stroking over the skin, stroking over the skin, this can lead to vasoconstriction, vasoconstriction. So because of this vasoconstriction, what is the color of the skin going to be? The skin turns white. Hence, we call it as white dermographism. It's a very important sign which can be seen in atopic dermatitis. Now, once I talk about dermographism, you need to also remember, like, where do you find a red dermographism? So please remember that red dermographism is seen in another condition which is called as chronic urticaria. Is seen in chronic urticaria. So for the purpose of MCQs, in case they ask you in the NEET PG, like where do you find a black dermographism? So black dermographism, this can be seen in nickel dermatitis. Nickel dermatitis. So remember these three very important things which is related to dermographism. That is, white dermographism is seen in atopic dermatitis. That is the topic of our day. Whereas red dermographism can be seen in chronic urticaria, and black dermographism can be seen in nickel dermatitis. So these are the various kinds of dermographism, and this is a clear-cut image where you can see that white dermographism has been demonstrated. That also white dermographism falls under the minor criteria. Now this is one more image which is a probable image from this topic of atopic dermatitis. Now what you find here is that you can see that there is some additional fold beneath the eyes. So these kind of additional fold beneath the eyes, these are called as the Denny Morgan folds. Denny Morgan folds. So these Denny Morgan folds are called as additional fold beneath the eyes. Additional fold beneath the eyes. Okay, these are called as Denny Morgan folds. This also happens due to chronic eczema or chronic atopy. So this is also seen as a part of the minor criteria in atopic dermatitis. Now, let us talk about the treatment part. Now, in the treatment part, how do we manage these patients? Because these are the patients who always have a very dry skin, isn't it? So dry skin, matlab what should be our mainstay of therapy? We have to moisturize, moisturize and moisturize. So moisturizing the skin is one of the most important part. So we have to apply body lotions, emollients, everything so that we keep the skin moisturized. Now remember, now in all these kind of patients, we have to ask them to follow some behavior modification. Like they should not be taking bath for a longer period of time. So they should restrict the duration of the bath. Preferably they should be avoiding hot bath, isn't it? Hot water baths should be avoided. And as soon as they come out of bath, in the damp skin itself, it is advised that they apply the moisturizing lotions so that the effect would be much better. So these are some of the advices that we can give. They should not be using some hard soaps. They should be using some soft, non-irritating kind of a soap as well. As far as possible, they should be avoiding those soaps with some heavy fragrance and all, because that also can lead to some kind of a allergy over the skin. So moisturizing the skin is going to be the first and the most important part. So whenever the patient is going to develop some kind of an itchiness, so during for this itchiness, we can always prescribe antihistamines. So we can always prescribe antihistamines so that like levocetirizine, cetirizine, fexofenadine. So all these are the antihistamines or the latest generation like loratadine. So all these things can be prescribed as an antihistamine because that is going to help the patient to reduce his itchiness. Now the mainstay of our therapy is always going to be steroids, because in any kind of an eczema, we can go for topical steroids. So we would preferably starting with a mild steroids, or according to the site of the lesion, we may have to use some very potent steroids like clobetasol as well. So we would be using topical steroids as the mainstay of therapy. The mainstay of therapy would be topical steroids. So all these things can be used: moisturizing, antihistamines, topical steroids. Now, in case the patient is having a very large body surface area that is involved, so the patient feels that I cannot apply a 20-gram or a small tube of topical steroids to all the parts of my body. In such cases, we also will have to go for systemic treatment. So we may use some oral steroids as well. Oral steroids can also be used for management. Other immunosuppressive agents like immunosuppressive agents. So what are the immunosuppressive agents that we can use? We can go for cyclosporin. Cyclosporin can be used. Azathioprine can be used. Azathioprine can be used. Even though methotrexate is not that much recommended, but still methotrexate is one of the options that can be used. Methotrexate is one of the options that can be used, but we would be giving more preference to cyclosporin as well as azathioprine. So all these can be used as a immunosuppressive treatment. Now, along with that, in case we are going to use the steroid creams for a longer period of time, that is not advisable, because steroid, they always come with side effects, like it can lead to skin atrophy. We can see some telangiectasia over the skin. So we don't want all these side effects. So we may also prescribe the patient with calcineurin inhibitors. Calcineurin inhibitors. Now, what are the calcineurin inhibitors that can be used for the management of atopic dermatitis? This can be tacrolimus, this can be tacrolimus, or it can be pimecrolimus. Can be pimecrolimus. So this can also be used for the management. Now, recently, some of the biological agents are also being tested. So the biological agent of our choice is going to be dupilumab. So dupilumab is going to be one of the preferred. So this is going to be the preferred biological agent that is being used. So this is going to be a monoclonal antibody. So dupilumab is going to be the preferred biological agent for the management of atopic dermatitis. So along with that, some of the newer agent of drugs which is also being used is crisaborole. So crisaborole is going to be available as a 2% ointment. 2% topical ointment is a preparation that is available for the management of atopic dermatitis. So crisaborole, dupilumab, along with that calcineurin inhibitors, topical steroids, oral steroids, immunosuppressive agents, all these things can be used. Antihistamines can also help you to come down with the itchiness. And remember, the main therapy should be, because we are trying to compensate this dry skin. So always we have to give preference for moisturizing the skin, even if the patient is having a symptom or no symptoms. So always moisturizing is going to be one of the main treatment that we are going to give in atopic dermatitis. So that is all about atopic dermatitis. So by this time, you know that which is the kind of patient who usually presents to you with atopic dermatitis. Dry skin, and also please remember the age. According to the age, the site of the lesions would be different. The site of the lesion would be extensor surface as well as a face when it comes to infantile AD, whereas in childhood and adulthood, the lesions are going to be seen over the flexural surfaces. And always the treatment will always comply of topical steroids and many other supportive treatment as well. Now let us quickly do some of the MCQs from this topic so that we have a small practice as well. A 5-year-old child was brought by his mother to the dermatology OPD with complaints of chest tightness, wheezing and shortness of breath for the last 2 months. During the same time, the child also had a gritty sensation and dry eyes. Similar complaints were also found in the grandfather for 40 years. What is the diagnosis? Now, from this question, it's a long question. So what do you understand? First thing you have to keep in your mind is the age. It's a 5-year-old child. Now, there is some wheezing, matlab that the patient is going to be a confirmed case of a bronchial asthma. So wheezing and shortness of breath is already reported. So there is some gritty sensation and dry eyes. So recurrent conjunctivitis, dry eyes, gritty sensation is implying some dry skin. Now there is a family history. Now who is having this family history? It is not the patient himself. It is along with the patient, it is going to be the grandfather is also reported. So family history is there, dry skin is there, wheezing is there. All these things is going to imply what is the diagnosis? The diagnosis here would be atopic dermatitis. Now in this option, there is a mention about pomfolix. So any idea what is pomfolix? In pomfolix, the patient, this is also an example of a eczema. So in pomfolix, the patient may complain of itchy vesicles over the fingertips or the palms and soles that is called pomfolix. So this does not fit into pomfolix. Now what is seborrheic dermatitis? Seborrheic dermatitis is what we usually call as the dandruff, isn't it? So this is what we call as dandruff. So this is not a case of dandruff or seborrheic dermatitis. And in the last one, there is contact dermatitis. So we know that there are two types of contact dermatitis. It is allergic contact dermatitis or irritant contact dermatitis. So this is not allergic contact dermatitis. It is not irritant contact dermatitis. The right answer here is atopic dermatitis. Please remember that sometimes atopic dermatitis is also mentioned as atopic eczema. It is also mentioned as atopic eczema. Okay? So please keep that also in your mind. It is both one and the same. So moving to the next one, let's see the next question. A 7-year-old child has a dry skin with frequent flares of bronchial asthma. No trigger was identified for the frequent flares of this condition. The sister is also having a itchy dry skin. What is the most common cause of skin infections in this child? Now, again, a child, there is a frequent flare of bronchial asthma and there is some dry skin as well, isn't it? So again, diagnosis to pakka, the diagnosis here is again going to be atopic dermatitis. Atopic dermatitis. Now, what is the most common infection that is associated with atopic dermatitis? Options are herpes simplex, Staphylococcus aureus, streptococcal infection, varicella infection. Easily हम rule out कर सकते हैं. This is varicella, which is not associated with atopic dermatitis, isn't it? But what is the most common infection? The most common infection is going to be Staphylococcus aureus. Remember, most in case they ask you what is the most common infection, always Staph aureus. Most common bacterial infection, also Staph aureus. But if they ask you what is the most common viral infection when it comes to atopic dermatitis, then the answer would have been herpes simplex virus infection. Fine. But here the right answer is going to be Staphylococcus aureus. Now let's see one more question. That is, a 1-year-old child presents with a dry face and lesions over the extensor surface. Mother is a non-case of asthma. So from these two sentences, we understand the diagnosis is atopic dermatitis. What would be the investigation of choice to reach the diagnosis? So they're asking you what is the investigation of choice. Now let's see the options. Patch test, serum IgE levels, KOH test, none of the above. Now remember, our diagnosis here is atopic dermatitis. So how do we make a diagnosis of atopic dermatitis? I have already told you that this is 100% clinical diagnosis. So if it is 100% clinical diagnosis, do we need any investigation to reach the diagnosis? No. So here the right answer would be none of the above. Now, in which condition is patch test the investigation of choice? Remember, patch test is investigation of choice for allergic contact dermatitis. So whenever a patient is having some contact dermatitis, contact allergy, we go for patch test. The second option, serum IgE levels. Please don't make a mistake that in atopic dermatitis, no investigation is necessary. Even though in many of the patients, you may find a increased serum IgE levels. But none of the textbooks, none of the criteria is going to mention that you have to frequently follow up with the serum IgE levels. That is not going to be a part of the diagnostic criteria. And KOH test is our investigation of choice whenever there is a suspected superficial fungal infection. Superficial fungal infection. So here the right answer is going to be none of the above. So now let's see one more question, like which of the following is the pointer of major criteria in the diagnosis of atopic dermatitis? The options are Hertog sign, Darius sign, pruritus, and white dermographism. Now they are asking you only about the major criteria. So which of the following is the pointer of major criteria in the diagnosis of atopic dermatitis? Now remember, we had three questions and one clinical examination when it comes to the major criteria. So Hertog sign, what is Hertog sign? Hertog sign means there is a loss of the lateral eyebrows. So we can rule out this one. It is not coming in the major criteria. The second one is Darius sign. Now where do you find Darius sign? Diarrhea sign is seen in urticaria pigmentosa. Is seen in urticaria pigmentosa. So which means this is not associated with atopic dermatitis. In diarrhea sign, what we do is we are going to stroke over the skin of a patient. So after stroking, the patient would develop urticarial eruption. So once the patient develops urticarial eruptions after stroking over the skin, then that's called diarrhea sign. It is seen in urticaria pigmentosa. So this also we can rule out. Pruritus is the next one. Yes. So our first question to any patient of atopic dermatitis was, do you have itchiness over the skin? Itchiness means pruritus. So the right answer here is going to be pruritus, which comes under the major criteria. Now, what is the last option? The last option is white dermographism. So where do you find white dermographism? White dermographism is also seen in atopic dermatitis, but it is not seen when it comes to major criteria. It is coming as a part of minor criteria in atopic dermatitis. Now, a quick question. I hope that you remember, where do you find um, red dermographism as well as black dermographism? Red dermographism is seen in chronic urticaria, whereas black dermographism is seen in nickel dermatitis. So please make a note of it. So that is all about the various presentations of atopic dermatitis, a very important skin disease for your NEET PG exam. And in this atopic dermatitis, remember all the important aspects as far as your NEET PG questions are concerned has been all covered, like the clinical presentation, what is the etiology, what are the exacerbating factors, how do you see the clinical symptoms, what are the major and minor criteria in atopic dermatitis, that is Hanifin and Rachka criteria. We also discussed about the treatment part. So we also discussed about some of the major MCQs that can be asked. So please don't make any mistake. So this is one of a very important topic, that is atopic dermatitis. So I hope that this session has been informative for you. So thank you so much for watching, and keep preparing. We will definitely come back to you with more and more live sessions like this, and more and more important topics shall be covered over a course of time. Thank you so much for watching. Stay tuned at PW Meded channel as always. Thank you.